Welcome, everybody. We're really excited to have you join us for today's webinar. We're really excited to be able to have this moment to be with you all. So thanks for your time. We're just working out one minor little technical issue. All right.
Hello.
Hi.
Sorry about the confusion. I'm like, where's the link? I'm not going to be able to get on.
That's okay. So we've already started. So
okay.
we're just all right. Now I'm able to share my screen. All right. So again, thank you everyone for joining us for today's webinar. We are really excited to have you all here today with us. We have actually been planning this series for a little bit, and we're excited to have our Health Center colleague, Jessica, join us today from Bighorn Valley Health Center, Montana. So we want to acknowledge that this webinar is being brought to you, is supported by funding with the Robert Wood Johnson Foundation. We are really excited that they're supporting our work in carrying through, how do we support health centers to collect social risk data, but more so act on that data. So just some housekeeping issues. This webinar will be recorded. Relevant resources and next steps will be emailed afterwards. We'll go through a little bit about Zoom in a minute. And we also want to acknowledge the new realities that we're all under right now. You know, kiddos, furry friends, unstable internet, renovations, all that sort. So please, bear with us if there's any technical glitch. But thank you again for joining us today. So this, if you haven't already been accustomed or used Zoom before, these are just some hints as to how to be able to use the platform and engage with it. So we've got a chat feature, we have a Q&A feature as well. You can raise your hand. So you'll all be muted right now so that we can have a seamless presentation, but we've got colleagues in the background that will be fielding those questions and being able to support you all during this webinar. Okay. So we're going to launch some polls right now. So let's see, because we want to get a sense of who's in the room. So the first question is, which standardized screener for social risk factors, if any, do you use? So if you can take a quick moment to answer that, that'd be great. Can you all see the poll right now?
Rico, yep, I can see it on my end at least from.
All right, great, thank you. So we know there's many different screening tools out there, so we want to be able to get a sense of what tools folks are using out there. So if you can take a quick moment to identify which screening tool you're using, that'd be wonderful. All right. So we're getting there in terms of folks being able to select which screening tool they use, or if they don't use a screener. And then we also have other questions. If you've stopped using your screening tool, we'd love to know that as well, or you're not able to ask the questions during this time. And then we'd also like to know which region you're located in. Again, we're trying to get a sense of who's in the virtual room, so to speak. So we're almost there. We'll give you guys about a couple more seconds to answer. All right. Thanks for those that have responded. I see some comments in the chat. Thank you for joining us and for being able to share. If you don't use a screener, that's okay. We're definitely, this is the purpose of this webinar, is to just provide some information for all of you. All right, so about 2 more seconds, and then we'll go ahead and close the poll shortly. There's more people answering, so I'm seeing the amount of people answering, so I'll leave it open a little bit longer. Okay. All right, so I'm going to go ahead and close the poll right now. Thanks to those that have who took the opportunity to answer. So we have folks here that are using several different screeners. So we have the Accountable Health Community Screening Tools. We have iHelp, Recommend Social and Behavioral Domains for EHR, PRAPARE, WeCare, WellRx. We also have other folks are responding with the screeners that they use in the chat box. Some people do not use a standardized screener. That's totally okay. And for some of us, it's not applicable, this question. All right. And then, so I'm sharing the results right now. So as you guys can tell, this is just, what's happening, who's using what tool. And then in terms of being able, if individuals have stopped using the social risk screening tool during COVID-19, we wanted to get a sense as to why. So yeah, it's a reality in terms of not being able to ask these questions. So we'll be sure to look at these responses later on so we can see how best we can fit the needs of all of you. But it's great to see that there's still people using it, and they're using it, they're acting on the data, which is wonderful. And then regions, all right, this is my favorite part, to see where folks are located in. So we've got quite a few folks in the Northeast. All right, so we've got representation from all over the United States, which is wonderful. So yeah, welcome again today. We're glad that you can join us. All right, so we're gonna go ahead and get started. Let's see here. All right. So for today's webinar, I've already went through some housekeeping. We're going to go a little bit into an overview of social risk screening workflow models, some ideas out there that we've got. And then we have, we're going to talk a little bit about SDOH data collection strategy. So in terms of SDOH needs as well as social interventions. And then we're going to hear from our colleague, Jessica, at Bighorn Valley Health Center. She's going to talk a little bit about their journey of how they've been able to use PRAPARE as one of the tools for social risk screening. And then we'll have some time for questions and discussion. We want to make, we allowed some time to hear from you guys, hear some questions that you guys have, and then we'll provide some closing remarks and resources. So this is the project team at NAC and APSHO. We have, like I stated earlier, we're receiving funding from Robert Wood Johnson Foundation, which we're really grateful about. This is the current team. We will be having a new team member join us next week, so you'll be able to see her in future webinars. But this is the current team right now. We also want to acknowledge our colleagues at Oregon PCA. They've been a part of the PRAPARE efforts since the beginning, so we want to acknowledge their efforts. They're part of our founding members, if you will. But for this program, for this particular project, it's a partnership between NAC and APSHO. And again, just want to thank our colleagues at APSHO. We are one team, and I'm really grateful for that. So I wanted to talk a little bit about as to why is this so important right now? And in terms of health centers, it's been interesting, when we think about the history of health centers, how health centers have been anchors in the community to really care for the community's most vulnerable population. And this has really been galvanized during COVID-19. So health centers have been able to adjust quickly and rapidly, and really think about how do we provide a continuum of care for our patients. We have been leaders in the field of social determinants of health. Maybe we didn't know about it, but it's something that we as a movement have really embraced and celebrated, and we're really trying to keep growing our capacity and our efforts in advancing health equity. So back in May and June, our team decided to do a pulse check of the field. We conducted a short or a invite-only community conversation just to see what PRAPARE users, specifically at health centers, what they were experiencing during COVID-19. And then also we had a survey, and we realized that based on what we heard from the field, that there was a need to revisit some of these, some PRAPARE topics, if you will, but really, how do we look at social determinants of health, data collection in general, regardless of tool? Yes, PRAPARE is the dominant tool, that health centers use, but we understand that there are many other tools out there, so we wanted to be cognizant of that. So we wanted to create this webinar series to really think about how do we help health centers in this time collect this data, to continue collecting this data, knowing that staffing models have changed, resources have changed. So how do we be as agile as possible to meet the needs of our patients? So hence we've got this webinar series, and this is the kickoff of our webinar series, and we're really excited that you're here with us today. So as part of the Robert Wood Johnson Foundation work, we've created a theory of change model, and part of the work that we're doing is really aligning or rather elevating and extracting what health centers are already doing and seeing how there's synergy with what's already out there. So with this webinar, we're really focusing on data, this element of data right here in the middle column, where we think about how do we create a shared data and measurement system that's really critical in terms of really understanding what's happening in our communities, what's happening across the nation. And so with this webinar, we're really wanting to focus on how do we collect this data to begin with, knowing that there's different varying levels of journeys, of expertise, of history with collecting this data. So we wanted to be able to align this with our national efforts at the Robert Wood Johnson Foundation. So for this first learning objective, we're going to provide an overview of strategies to determine which social risk screening workflow model works best for your organization setting. I will be referring to PRAPARE as one of the tools, but again, it's not the only tool. So first and foremost, why do we collect this data? So we collect this data so we're able to understand what the level of complexity of our patients. We see it, we feel it, we know it every day in our health centers. So being able to define this and to document this complexity of our patients allows us to understand what's really happening in our patients' lives. From there, we're able to target and really prepare or understand how to provide the best care for our patients, be it clinical care services, enabling services, and then really thinking about the healthcare team outside of the health center and seeing what are community partnerships that can help us drive transformation. We also know that this data allows providers and health centers to demonstrate the value that they bring to patients, communities, and payers. The level of care and the model of care at health centers is so complex and comprehensive that it's really, this information really allows us to demonstrate that. And it's really important, especially in these times. And then finally, allows us to be, to continue our role as advocates and change agents in our communities. Be it at the local level, state level, or even national level, this information really is powerful and allows us to move forward and to advance health equity. So these are the different levels as to being able to collect this data and how we're able to make impact at the various levels. I won't go into too much detail here, but as we can see, this data is very powerful. It informs individualized care, but then, like I said earlier, it can help inform national policy and efforts to improve care across the continuum. And really what we're all thinking about and what we're all really working towards is health equity. How do we advance health equity? We see the health inequities and the disparities in our communities. We see the burden of disease on some of patients that are impacted more versus others. And so really being able to understand how does this impact our communities and be able to advance health equity to see what are the gaps in our care systems and social service sector. But really in achieving health equity, we want to make sure that everyone has the fullest potential to reach their healthiest self. We know healthy communities are made of healthy individuals and healthy families. So we really have to make sure that we're able to have this data so that we know how to align our efforts and move forward. So in terms of building capacity to respond to SDOH needs, there's 3 ways to look at this. When we think about, sorry about that. When we're able to think about building capacity to respond to the needs of our health centers, we have the people. We have to think about the people first and foremost. What times do they have? What sort of roles do they have? And especially during COVID, how have their roles changed? Then we look at the processes. What are the workflows that are currently in place? How do we make adjustments to that? What are some partnerships that we need to look at? And then finally, we have technology. And technology is able to leverage both people and processes. one thing that I like to say is that technology is a reflection of everything they have that's offline. So it's really important to take a look at the first two buckets in terms of people and processes, and then we're able to really leverage technology to our best capacity. So within the PRAPARE toolkit, we did adapt this framework. I'm not sure of the source, so don't quote me on it, but we did adapt this framework in terms of the 5 rights framework. And it's really thinking about what are the different considerations that we need to have when we're determining our workflows. What is it that we're trying to collect? So within PRAPARE, what information are we collecting? What is already routinely collected? And then we have to think about the how in terms of what's the right format. Is it a self-administered assessment? Is it in person or over the phone with the staff member? What's the best way to collect this information from our patients? And then who's the right person? We've heard from the field that there are different individuals in the clinics, in the health centers that are asking these questions. And depending on the makeup of your health center, it's really important to think about who's collecting this data. Is it providers, clinicians, or non-clinical staff? And then the big question is, when is this information collected? Is it before the visit? Is it during the visit? Is it after the visit? So these are things that you have to consider as you're thinking about implementing PRAPARE or any other social risk screening tool. And then the final question is where? Where should we collect this information and where do we store this information? So these are the 5 rights. This is a very helpful framework in terms of understanding how to best leverage our staff and our procedures in the health center. So one of the activities that our colleagues at the Oregon PCA, they did this wonderful activity, and I'm a big fan of it. They invited their health centers to pick a patient population. So if you're a health center that hasn't collected social risk data, or you've started and you're running into some little bumps in the road, if you will, pick a patient population and then interview 10 patients using 3 questions for PRAPARE or another screening tool. And this is a great way, it's a nice way to pilot the process and think about what's the best strategy in terms of asking these questions. So, afterwards you can do a debrief and think and meet with the team to see, what did you and the patients discuss? What were some observations of the process? Was there some unintended consequences, if you will? Maybe there was delayed the visit, or maybe there was some confusion. But what we will also want to be able to evaluate is, did these questions lead to conversations about other topics with patients? That's one thing that we've heard from the field, is that these conversations, as hard as they may be, these questions really lead to more rich conversations with our patients. And then finally, another important question is, how do we envision using this data to inform care? And like I said earlier, the individual level with our patients, but then how do we inform population health efforts so that we improve the health of our communities as well? So this is a great quote. Without data, you're just another person with an opinion. And this quote is really powerful, because we feel the burden of the social determinants of health. Some of us personally, some of us within our families, but obviously being within health centers and being within the field, we feel the burden of the impact of social determinants of health. But it's one thing to feel the burden or to feel the impact of it, but if we don't have the data to match that or to tell the story or capture the story, then it's really hard to really drive any sort of systemic change. So then in this second objective, we're going to review some data collection strategies for health centers to screen, collect, and crosswalk their data in terms of SDOH needs and intervention data. So when we think about the data that we're collecting at our health centers, we really have to take a step back and think about a conceptual framework in terms of being able to think about the ecosystem of data that we're collecting. So obviously we have the social determinants of health. And then the other bucket of data that we're collecting is what the care that we're delivering. So in terms of screenings, any test procedures, any other sort of care that was provided to patients, that's another bucket of information that we're capturing or collecting. And then the other bucket that we have is health outcomes, and that's in terms of utilization, cost, ED visits. Those are three different buckets of data that we're collecting, and thinking about the ecosystem really allows us to think, okay, how do we map this out? How do we consider the data that we're collecting? And underneath all of this, we have enabling services and non-clinical social interventions that support our patients throughout this process. So this framework really, I just want to invite you to consider the fact that the social determinants of health data is just one piece of the puzzle. And being able to have this data allows us to work in the different buckets, and then is all supported with enabling services and social interventions, which is really where the magic happens, if you will. We're able to see improvements in the patient's health, and then, but really in their quality of life as well. So when we think about SDOH data and enabling services data, they're both sides of the same coin. All right. So on one side we had the needs data. It's how do we establish a standardized protocol so that we collect the same information across all health centers, across any setting really. What are the patient's risk factors or barriers, or what is it that we need to consider in their care? And then we think about it on the other side, we have to respond to this data, right? So how do we standardize the collection of intervention data? Because this complete story really is powerful and allows us to understand what's happening and what is it that the bodies of our patients are telling us in terms of the impact of the structures and the systems and the policies that are impacting health at the community level and in the individual patient level. But then what is needed to offset or mitigate what's happening? So really this data is powerful. We need one. We have to have both. We can't have one without the other. Again, it demonstrates health center value to payers, allows us to really try to seek adequate funding and financing, sustainability of health centers. But then knowing that resources are limited and staffing is limited, how do we target and improve our services, understanding what's happening in the field? And then ultimately, we're hoping to achieve integrated, value-driven delivery system so that we can have better quality, better outcomes at a reduced cost. So when we're thinking about our data collection strategy, one of the things that we encourage all of our health centers to do is to think about what data you're already collecting. We don't want to double document our patient's story, if you will. We don't want to, create more work that's really unnecessary. So take a look at any intake forms. Think about any other screenings that your health center is already doing, possibly like SBIRT or maybe anything that's related to trauma, or possibly substance use. So think about other screenings that are happening in the health center. Where is the information already collected, and where is it sitting at or being stored in your health center or in the EHR? Within PRAPARE specifically, we do already have templates that have already been mapped out to a practice management system, or some of the templates automatically pull from other parts of the record so that it auto-populates and you don't have to double document. But really, this is what we're hoping for, is that we take the step back to say, where are we capturing this data and how do we account for that? So again, PRAPARE is one example, and wanted to show very briefly the screening tool, the core questions or the core measures that we have in the PRAPARE tool. We have 16 measures, and out of those 16, 9 are already a part of UDS. And for those that don't know what UDS is, the Unified Data Systems. And really, that's the reporting mechanism for health centers that are funded by the Health Resources and Services Administration, HRSA. Okay. Then we've got optional questions. So aside from the core measures, these are the measures that our stakeholders and everyone that was involved in this process felt was really important to collect. But we also identified optional measures that would be helpful should health centers decide that this is something that they want to ask about in terms of their patients. So we have a PRAPARE coding and data dictionary here. It's a wonderful way to think about how does this all look, how is this all interconnected and interrelated. We do have webinars on this in terms of our website. So take a look in terms of getting more information in terms of how this has all been mapped out with other efforts across the country. And just finally, before I hand things over to Jessica, we hear a lot about different challenges from our health centers, right? We see and we hear that there's There are different challenges, and what is it that health centers are doing to respond to these issues, right? So we know that there are competing priorities. And so one of the things that we like to tell our health centers is, see how we can align with other initiatives that are happening. Another question or another challenge that we hear is, how do we implement this without increasing the visit time? And one of the things that we can do is, as a health centers, is take a look at what are some value added opportunities within the visit that we can ask these questions. Another major concern of many health centers, and I'm imagining now more so than ever, is the inability to address SDOH. So with this, we have to say, every health center is at a different part of their journey, and being able to ask these questions, we have to start somewhere. So even if we don't have all the resources, and we shouldn't expect health centers to have all the resources in-house, but where should we start? If we're able to develop some community partnerships, what are the highest needs from our patients, and then we're able to focus our resources there. Another issue is staff turnover at multiple levels, be it a health center or a primary care association or health center controlled network. So it's really important that we think about how do we involve different staff throughout the organization so that everyone's cross-trained, everyone has had at least some level of exposure with PRAPARE or the other screening tools that you guys use. So that's something to consider there. And then with PRAPARE specifically, one of the benefits of PRAPARE is that, it's flexible enough that you can fit it into any existing workflow. So really think about, again, any other risk assessments that you're already doing and how that can possibly fit there. So now, hold on one second. So now we're going to hear from Jessica. So here, we're going to hear from Jessica at Bighorn Valley Health Center to see what their journey has been in terms of collecting social risk data. So now Jessica, I'm going to go ahead and advance the slides for you. So just tell me when to go. But if you can, just please give us a very brief overview in terms of Bighorn Valley Health Center, and then we'll go ahead and continue with your part of the presentation.
Sounds great. So hi everyone, my name is Jessica Mussetter, and I am the current Optimal Performance Manager, but formerly the Health Advocacy Manager. So I lead a team of community health advocates, also known as community health workers, depending on where you're located. So Bighorn Valley Health Center is a federally qualified health center in rural Montana. So we have 5 locations across the state. So we kind of started, I guess I could kind of start with why we chose to do PRAPARE. So in my role, we refer to ourselves as the resource team. So we're part of the care team, the primary care team, and we help connect patients just with resources outside of the healthcare setting. So studies show that a person's health is impacted, I think it's like 80 to 90% by factors outside of the clinic. So that's a really, that's a huge job, and that's a really, really important job. So one kind of, I guess, explanation of that would be like if we have a patient that has like an out of control A1C, they're diabetic, and that's something that we're working towards is to help them improve that goal, but they don't have a safe place to sleep, or they're not able to purchase healthy food, or they don't have a refrigerator to keep their medication. So then that's something that I would try to help them work on patient empowerment and get them connected with those resources. So we found out about PRAPARE and decided that we really wanted to be more intentional with how we were capturing and helping patients get connected with resources. So we at Bighorn Valley do Lean Six Sigma. So this was my Yellow Belt project, if any of you are familiar with that. And so that gave me the opportunity to really deep dive kind of what they were talking about earlier in the presentation, like doing an audit of the EMR and figuring out where is this information already being asked and all of that. So we'll go into that. So for this slide, I just want to talk about why it's important. And I think we talked about it a little bit, before, and you all understand that social determinants of health is huge. So with this, I was able to actually take the information captured from the PRAPARE data and apply for a grant to get an in-clinic food pantry. So I have in clinic now 250 food boxes for immediate use. And so this was something that we were working on before COVID, but then after COVID hit, it just became apparent that that was an even bigger need. And so we're actually pursuing an even bigger grant to expand this across all of our locations. But I bring this up because had we not had the PRAPARE in place, I wouldn't have had the data captured to show that need. That quote that was shown earlier, without data, you're just a person with a opinion. And that's true, because we all know that this is a huge issue. We know that social history or social determinants are really important. And without the data, I wouldn't have been able to pursue this. So you can go ahead and change the slide. So in this one, we'll talk about workflow. So this was touched on a little bit before too, like who would do the screening? Where would the screening be done? And so with that Lean Sigma training, we went through and talked about all the different factors. Do we want to do a paper form? Do we want to allow the patient to do a self-assessment? And what we came to is that we really wanted the opportunity to talk to the patient personally. So we use empathic inquiry, and we try really hard to motivate the patient, understand where they're coming from. So it's almost like a brief, I don't want to say counseling, but really just getting a feel for where they're coming from. And so we decided to do them in person. We also decided across the organization that it would be done by the nursing and MA staff. And so that might be, a little bit different than how other sites are doing it, but we agreed as an organization that every patient will come in contact with a nurse or an MA during triage. And so we timed it. And if a patient doesn't have a positive need, if it's just pretty basic, which we show that it's about 20% of all PRAPAREs are a referral to a community health advocate. So those patients that aren't experiencing any issues, it takes about 2 to 3 minutes to complete the screening. So that's important to note when you're having a conversation with providers, because we know that they're always strapped for time. So here's the nursing MA staff workflow that I put together. And so we can kind of take a little bit of time looking through that. So nursing staff would room the patient. We always ask the patient, do you agree, to this PRAPARE screening? So that conversation usually looks something like, I would say, my name's Jessica, I'm a community health advocate. We are capturing data so we can, get a better idea for where you're at, see what resources might be available to you, as well as capturing data to improve our community and adapt future resources. Do you agree to that? And the patient would say yes or no. I've only had 2 patients decline in the 2 years that I've been doing it. And that was because of time constraints. So had nothing to do with that they didn't want to do it. It was that, maybe they were running behind or needed to get back to work or whatever it was. So I note that because I really just want everybody to know that I think people are interested in answering these questions and being a part of a bigger picture. And so that's why I put in that piece where I say it's an opportunity for them to help improve their community, because it really is. So we can go ahead and change slides. So this is what it looks like in our EMR. So we have Athena as our EMR. What we found is that this EMR was a little bit hard to work with in the beginning. They hadn't developed a template at this point, and I think that they are in the developing process of building a template. What we found, interestingly enough, we met with an Athena rep that is building the template, and his template looks a lot like what we had built as a quote wraparound. So that's kind of exciting because our thought process was in line with the Athena developer kind of thought process. So what we do is we have this listed in our social history tab in the EMR. So the nurse would triage the patient, would go into the social history tab. Right here, prepare screening date. That's really important because we pull this data every single day, and then we put that in a dashboard, and there's a slide for the dashboard later on that I'll explain. So we make sure that we put in the date, and so that's important because we prepare every patient every time is our goal. And the reason for doing that is that we know that a patient status can change so much between visits. So we really wanted to give them the opportunity to have that time with us, have that be a topic of conversation, really kind of instill in people that we practice whole health. And so we really care about those needs. So if something does come up in between visits, it's in the back of their mind that we ask these questions. And if it comes up, they can always come and talk to us about, whatever the issue might be. So all of these fields in the middle are reportable. The notes fields are not reportable. So we use the notes fields just when we're doing the interview so we can go back and chart if there was a quote positive from that referral. You can go ahead and change the slide. Okay, and then so one thing to note if you do have Athena is that we have found the questions don't always stay in order, and that's kind of a problem. So anyways, just a little bug there if this is something that you are trying to develop on your own. So out right here at the bottom, I just want to note that we have a little spot where we put, I choose not to answer the prepare questions today. And so we really give the patient the opportunity to opt out if they don't feel comfortable answering the question at that time, and that's totally okay. I also want to note that we have a Montana Legal Services partnership. So so that screening tool was developed off of PRAPARE. So in that audit process, we made sure to look at what questions are already being asked on the Montana Legal Services referral or screener, what questions are PRAPARE, what questions like income, age, ethnicity, those are already being asked in our intake. So making sure that we are not asking those questions multiple times. So in here, you might see some of the questions like other legal issues. Those are from the Montana Legal Services referral. So we're kind of doubling up on the screener. So our PRAPARE is actually 2 screenings. Is there a way that I can turn off the chat bar? It's like distracting me. There we go. Okay. So in that, this is how we do referrals off of that. So let's say that we screen a patient, they have a quote positive need. So let's say that we have a patient that's going through a divorce and she would like they would like a referral to a community health advocate to do a MLSA referral. There are multiple ways for a provider or anyone on the care team to do that. So they can do a referral through Athena. And so it's called a patient case. So they can send it to a resource bucket that notifies everyone on our team that has been sent, and we can address it that way. We utilize Teams as an organization, so we have a public Teams channel for the resource team, so anyone in the organization can send a message there, and a community health advocate will address the need. And then we also utilize TidoCare for telehealth, so that's the platform that we use for telehealth. All of our community health advocates are able to use that TidoCare platform, so during the pandemic, we were able to do like Medicaid applications, housing applications, referrals to the food bank, things like that through TidoCare. In-person warm handoffs, if able, that is ideal, right? I would rather meet with someone in person, but with the pandemic, we know that we've had to kind of change how that goes. Okay, so I see a question here. Can non-clinical staff conduct the survey? When are the PMP available? Okay, so I think what you're asking is, can other people conduct the survey? And the answer to that is yes. So we have only trained community health advocates and MA's nurses at this time, just because we wanted to make sure that it was really intentional. But as long as the protocol is followed, as long as it is addressed in the EMR, yes. Okay. If a patient is a dental patient but not medical, does your dental staff provide the PRAPARE question? And the answer to that is yes. So we have one dentist, and she's at our Miles City location, and the hygienists are the ones that do the PRAPARE there. And then they do the referral same as everybody else. So everybody follows these referral options. It doesn't matter what their position is in the organization. Go ahead and change the slide. Okay, so something that we're really trying to develop is tracking those the health outcomes. So if a patient is positive on a PRAPARE screening and they do a referral to a community health advocate, and we work with them to get them connected to behavioral health, a third party, housing, whatever that what might be, is there data that shows that we are improving their health outcome? And so that's something that we're still working on. I have a feeling that that's going to be more complicated than we had originally thought that it would be. But we have developed a PRAPARE dashboard. So if you want to switch the slide, I think it's the next one. Yeah, so this is the PRAPARE dashboard. We have this in our Teams channel. And if any of you utilize Athena or are interested in this, I will make sure that my contact information is added to the follow-up email, and you can reach out to me, and I would be more than happy to talk about this. But this is this just shows the amount of screening. So the blue, if we're up here on number 1, the light blue here are the opportunities. So we don't screen patients that are under the age of 18. We don't screen patients that are in for DOT or disability exams, and we don't screen patients that are incarcerated. We don't have the capacity to assist patients that are incarcerated. Really, it didn't really make sense. Some of the PRAPARE questions didn't make sense because they are not, because they're incarcerated, I guess. I'll just leave it at that. And then DOT and disability exams are very strict on what you can do at those visits, so we don't screen for that. And then we have a screening that is for adolescents, so we use that screening instead of PRAPARE. And then the purple are the ones that were completed. So you can see on 3 that through our entire organization, there were 295 people that were identified for screening. At the time that this screenshot was taken, 123 complete PRAPAREs were done. We're also developing this dashboard a little bit more, so it's more in depth, so we can see specifically for providers, like what provider team does the most, struggles, has the most community health advocate referrals off of it, those types of questions. So that way we can really get to the bottom of like maybe what provider needs help, kind of go from there. Yes, so the dashboard was created using Power BI, and then we pull the data from Athena into Power BI and then house it in Teams. And then I'll answer these other questions in a second.
I was going to say you can hold off on the questions when you're done. So
sounds good. It pops up and then I get distracted, so I'm like, I'll just answer it.
That's okay. Thank you for answering them though. Go ahead. Yeah.
So just so everybody knows, we just developed this dashboard, I think 3 months ago. So it's new. We're still working out the kinks. I've been retraining on PRAPARE across the organization, and the providers really want to know their specific numbers so they can compete with each other, which I think is funny, but it also helps me to help them. If I can see that a provider team is struggling, I can really go there and help that specific provider team figure out the kinks of their workflow. But it is also leverage because providers want to, we've found with screenings, they want to compete with each other and say, oh, well, I completed 100% of my PRAPARE screenings and you only completed 80 or whatever it is. So that's side note on that. You can go ahead and change the slide. And then again, like I said, if you guys have any questions on that dashboard, totally reach out to me afterwards. So to kind of go off of the question of can non-clinic staff do PRAPARE, this is another option. So we have a partnership with the food bank here in Hardin. And so we have developed, so this actually I did not build, can't take credit for this. This was something that came from the Oregon PCA, but we are using this at the food bank to do referrals for our community health advocates or third party from the food bank. So we're still kind of working out the kinks here, still trying to figure out the best way to use it, but we decided to use the icons because we have some patients that maybe have a lower level reading and or English is not their first language. So the icons are much easier to effectively communicate their needs there. Another development off of this is we started what we call an app night. And so our community health advocates go to the food bank. This is pre-COVID. We go to the food bank once a month for 2 hours, and we would have an appetizer, and then we would do an application. So we would pick like a LEAP, Medicaid, SNAP, or something along those lines. But this PRAPARE screening tool was a catalyst for us to help and address other social needs. So that's another option if you guys have like a community partnership or want to develop a community partnership. This type of screening tool I think is a really great way to do that. You can also do the complete PRAPARE. It just takes a bit longer. So this one's almost like a pre-screener to help kind of develop, you know, start that conversation, develop a workflow, and figure out how to get patients connected in the community. Change the slide. So what have been lessons learned? Do you want me to just answer these questions?
Yeah, so figured this would be like the interview portion. So,
okay.
So I'm looking at time, and I know we do have some questions down there. So I'm just gonna pick a couple here, and then we'll go back to the Q&A section. So Jessica, just thank you for sharing your story and just the incredible work that you guys are doing at Bighorn Valley Health Centers. It's really incredible. So I guess I'm wondering, you know, in terms of, I guess I want to start with question number 3 in terms of how is the health center documenting social interventions, if you guys are?
Okay, so right now what we are doing is we're documenting all of our connections in a spreadsheet. This is not ideal. My team is becoming certified as certified community health workers, and once that is complete, we are hoping that we will be able to be listed as like support sidebar providers in the EMR, so that way we can effectively document and have this information in the patient's chart just to help with that continuity of care. But at this time, we're tracking it in a private spreadsheet where we document the need that was met and the status of that, so that way we don't lose progress while working with that patient. So like I said, we're still developing on that, but that is a very high priority for next steps for the project.
Great, thank you. And then I'll ask the last question is, what tips do you have for health centers that are looking to either begin or enhance their strategy to collecting and addressing SDOH needs on their patients?
I would definitely utilize the tools that are on the PRAPARE, is it the NACHC website? I think
it is.
Yeah, so the toolkit is amazing, extremely helpful. They have an audit. I think it's called an audit or something along those lines, and it really helps you like go through and think like through every step of it. I think that is so important. I think what I found is having the right people at the table when you're in the planning stages is vital. So it happened where I implemented the project and then went to the sites and started training, and providers had a hard time with the fact that I didn't talk to them about some of these things before we implemented. And so I would really encourage that you invite providers to be a part of this conversation, because it will impact their workflow. I mean, the point blank, it will take time out of their appointment slots. And I think that most providers are on board with it. They think that PRAPARE is very important. They want to help address this need, but they need to be a part of that conversation. So I would say my biggest tip would be to really just make sure that the right people are at the table.
Okay, great. Thank you. So we're going to go ahead. I'm going to open up the Q&A portion. So she already answered, she answered the question. Jessica, thank you for answering the question about the dashboard.
Sorry about that.
That's okay. That's wonderful. So we have a question here about, can you elaborate on the adolescent screening? How is it different? Does the patient or the parent complete? Do you guys do adolescent screenings?
So we do a PHQA, and that is for, I think it's below the age of 17. I can't remember on that, but I can get more information and you can send that in the follow-up email. But the reason that we chose not to screen adolescent patients with the PRAPARE is because it asks questions like, can you pay your electric bill? Are you afraid of losing housing? Which, definitely can be relevant to some, but I literally went in to screen like an 8-year-old, and asking those questions seemed really silly. So we were like, okay, we need to back up and reevaluate that. So that's the reason behind it. And I can get more information on the screening that we do use.
Okay, great. And just to let the rest of the attendees know that, our team is looking at making some changes to the screening tool so that we can ask, understanding that children are part of families. So how do we ask these questions so that we, understanding that some of the pediatric patients will not be able to answer these questions. So thank you for that insight. All right, so we have some comments here. I'm just going to dismiss these. Yes, competition is a great way to use incentives. Absolutely. I am working with clinicians in the past. That is the best way to get them going. So thank you for sharing that.
I've also bribed people with food, and that to work really well.
By any means necessary, right?
Yeah.
Yeah, so we definitely hear the field in terms of wanting to do this with pediatric patients. So stay tuned for that. So we have here, how do you keep track of community service providers changing resource availability? So I guess, do you guys have a resource book, or how do you guys track any sort of changes, especially given that right now in the time of COVID, resources are going to be changing within our community social service sector. So
Yes.
Can you talk a little bit about that?
So this is a great question. I think this is something that's always developing, especially in a time of COVID, but we have a resource binder is what we call it. We try to keep that updated with, pertinent information, phone numbers, applications, those types of things. In Montana, we also have a website called Montana 211, and it's a statewide directory. So you can put in, I think it's your town, you put in your town and or your county, and then you can search resources that way, and it can pull up. So I can send some examples of what that would look like for the follow-up email as well.
Great. Yeah, that's 211 is an effort from United Way. So I think in most states and areas they have United Way. It just depends on the makeup of the communities and what's available, but it's definitely a good first step. So if you have that screenshot, that'd be great to see it.
The other piece on that would just be to really have solid relationships with like your OPA and your HRDC offices and your food bank if you have one. Those are invaluable connections to me because I can, just call them up when I have a question, see if there is a resource available.
It's always good to have, those relationships that you can just quickly speed dial them,
Yes.
All right, so we have another question here in the Q&A section. So are providers involved with addressing SDOH with clients during their medical visits? If so, how is that process going? And are there any policies or procedures developed as a result of SDOH?
Yeah, so the answer would be yes. As far as the policies and procedures, I'm not 100% sure on that. I mean, I think the biggest thing I can speak on would be PRAPARE. And so we are preparing every patient. I do know that we talk about substance use, we talk about, all that kind of stuff. As far as policy and procedure, I'm not 100% sure on that one though.
Yeah, I think when I hear that question, I think of, understanding you know, if we have a positive screen for domestic violence or housing, like what are the next steps so that we're able to address it? So I think most clinics or health centers, they try to develop some sort of standard work, if you will, so that everyone's on the same page, understanding, you know, how to address these needs. So we can definitely talk about that. That's what I understood. If I'm mistaken, please put that in the Q&A section. All right, so the next question is, we have, let's see here. We have a person that they're planning an SDOH QI pilot using PRAPARE with resident providers using paper forms. Does that sound reasonable, or we need to take a look at EHR integration first? I'm going to take this question first, and then Jessica, you can answer. I think it's great to start with the residents. I think they're usually really willing to try new things, and using a paper form, I think, really helps you understand as a team how you're going to collect the data and how you're going to respond to it. Any way to get started is really reasonable. I'll be very honest with you. I use a PDSA. I'm a big advocate of PDSAs. But if it's already integrated in your EHR, then maybe it's a good time to take a look as to how that looks like in your EHR. Because if it's already in there, then maybe see if what's in there, and then you can pilot it and see how it works. Jessica, would you have anything else to add to that question?
I would agree, and I'm getting some feedback, sorry. I would also say that we started with a paper form in the beginning, but the reason, you know, it's hard to track that data, I guess, is the biggest thing. And I would agree with using residents. I think that is a really great option. I also agree any starting point is a good starting point. The reason that I didn't want to use the paper form, though, was tracking purposes, and because I wanted to make sure that I could help, you know, like, so we have 5 locations, and so the paper form wasn't really a good option for me to be able to be a part of that, right? So it had to be electronic in order for us to do that. And also, in order to build a dashboard, it really needs to be electronic, and just, you know, for safety, PHI reasons, keeping the information safe. It's always good to have it in the EMR rather than on paper, I would think.
Absolutely. I agree with you. Maybe start with paper, like 1 or 2, but then definitely move on to EHR.
You could do paper and then keep it, you know, try to input the data in a private spreadsheet, a secure spreadsheet or something like that, and then shred the form or something along those lines too.
Okay, so I'm looking at time, and I know we're about to, you know, be ending on time, but we have one last question here is, how do you navigate the safety and DV questions if there are multiple people, partners, children in the exam rooms? Okay, so
that is a really good question. I have personally experienced this twice that I can think of, and the abuser was in the room. And so what we actually did was kind of team up as a you know, a care team, and would would separate them, essentially. Mm-hmm. We would do that in a way that was non-threatening. So, for example, the nurse and I would work together, and so the nurse would go and just say, hey, I need to speak with you in the hall or whatever, and then I would go in and do the PRAPARE that way. So we were getting accurate data and not accurate data, we were getting accurate answers, and really able to speak with the patient in a way that, you know, was non-threatening.
Great. Thank you for sharing that. That's definitely a big concern, you know, with patients, you know, that's something that we want to be able to have a level of privacy and confidentiality, because it's very sensitive information, and we want to be cognizant of that. So thank you, Absolutely. Jessica, for answering all these questions. We know that there are more questions in the chat box, but we don't have time to answer them. So what we'll do is we will copy the chat box so that we are able to answer them. And so I'm just going to start wrapping us up. So again, thank you, Jessica. I can't tell you how thankful and appreciative we are that you joined us today.
Yeah, thanks for the opportunity. I really appreciate it.
Awesome. So in terms of next steps, again, the webinar was recorded, so we'll be sure to share that. We will be launching office hours soon, so we'll use some of those questions, and we'll let you guys know about the office hours so that you know, we can have the time to have these questions, these discussions, so that you have the information that you need. Once you click out of the webinar, you will be asked to complete an evaluation. Please, 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 in the spirit of continuous quality improvement, we want some feedback. So please let us know how we can improve and what you thought of the webinar. And also you'll have an opportunity to share any topics for future webinars that you'd like to see. So please share us your thoughts and your recommendations, and we'd love to hear from you guys. So we do have 2 more webinars coming up. October 22nd, we have practical strategies for social risk screening during COVID-19. And then the third one is emerging strategies to address SDOH through community referrals and cross-sector partnerships. Those registration links are coming soon. We're just wrapping up some details. So we want to make sure that we have the right information. But again, those webinars will also be recorded, but we will be featuring community health centers at each of these webinars. So, you know, we value the experience and the expertise of our health centers. So we want to make sure that we lift up their experiences in these webinars. Also, we have a call for innovative practices for health equity. We have another project that's funded by the Robert Wood Johnson Foundation, and they've put out a national call, and we want to help elevate the amazing work, the innovation that's happening at health centers. So if you have a moment, please take please look at this survey. It might look a little long, but don't be overwhelmed by it. But we'd love to hear from you. Don't think that anything that you're doing is not an innovation. So please tell us your story. We'll want to hear from you, and help us tell the story of health centers across the nation as we share this information with Robert Wood Johnson and other grantees and other organizations across the country. We want to make sure that health centers are represented and the voice is there within all of our information. We'll send out the slides, but we do have PRAPARE related resources. Again, like Jessica mentioned, there's a lot of resources that we have within the implementation toolkit. So definitely check out our website. I know they're dropping in the links in the chat box, so definitely take a look at that. And then obviously COVID, you know, we both organizations, both APCHO and NAC, we have resources for our constituents. So please take a look at our respective websites for the latest information. And then in the time that we're at, we want to encourage all of you, whether you're a health center or not, please be an advocate. We want to make sure that there is long-term funding, stable funding for our health centers, especially considering the impact of COVID and how long-standing it'll be. We need to make sure that health centers are stable in terms of financing. So please check out our website in terms of how to become an advocate. There's a ton of resources. If you don't feel comfortable being an advocate, we have the team for you at NAC. So please check that out. So thank you so much for joining us today. We appreciate your time, your energy, but more so your dedication to keeping our communities healthy, and hopefully we'll be able to thrive really soon once we come out of COVID. Thank you and have a wonderful day.